Thank you, everyone, for joining us. Hopefully, this will be a very productive session. I think today we're going to be addressing a lot of important issues on TAVR relevant to our patient population, especially in the region with a lot younger patients. So we'll be talking about the lifetime management of a patient with aortic stenosis. I think this is a very important issue. Valve durability, and also clinical relevance to patients and valve and newer technologies as we head in the future. So we'll kick off the session with our esteemed panel. Joining me on the panels will be Dr. Mirvet Al-Asnag, Dr. Ahmed Al-Shati, Dr. Jeremiah Depta, and Professor Vito Ruggieri. And we'll start the first session by Dr. Mirvet talking about lifetime management of AS.
Well, good morning, everybody, and thank you for the invitation to be part of this discussion. I think as much as I would like to deny that there's an issue with lifetime management, it is a reality. And I don't really have any relevant disclosures for this presentation. I think we were all excited about starting our TAVR programs, and as we started these TAVR programs, we saw that we started with inoperable patients, and then we moved on to high risk, intermediate risk, and now even low risk patients. But with it comes a responsibility to discuss potential issues that arise in the future. One is coronary access, pacemaker rates, paravalvular leaks, hemodynamics of the valve, and of course, durability of the valve and the need for these kind of patients to move on along the spectrum into a second procedure that takes you right back to the beginning when you're reconsidering a second procedure, talking about coronary access, pacemakers, PVL, hemodynamics, and durability of the second valve, and so on. So what we do know, this is from the Oxvalve PCS registry that came out of the United Kingdom, really, and what they did see is that what we see in clinical practice is really the tip of the iceberg. We're seeing the patients who come with advanced symptoms, when in fact there's a whole layer of patients that we do not see, who have significant aortic stenosis and are underdiagnosed. We're learning to pick up these patients earlier, and we are learning to treat them and offer them options sooner. And as I said, we moved on from prohibitive risk to low risk, and the NOTION trial was the first randomized trial that actually looked at low-risk patients, comparing TAVR to SAVR. And we have 8-year follow-up that has been published and released for these kind of patients. And most important, when I look at the NOTION trial, is looking that over the last 5 years, the intervening sooner on AS has become a reality, and offering TAVR to low-risk patients is also another reality. So when we look at coronary access, and the increasing lifetime risk of coronary access is real, and it's a dilemma, and this is the focus of my talk. There is a high prevalence of coronary artery disease in patients with aortic stenosis. Procedures are getting safer, with long-term aspects becoming more relevant, and preventive or preemptive PCI for patients undergoing TAVR is still up in the air. There's some preliminary data that suggests treat it like stable disease where you don't need it and fix the valve. But patients are getting younger, and so a conservative approach regarding PCI prior to TAVI, although adopted, we need to be cognizant that in the future, we may need to revascularize the coronary arteries because the patients are no longer quiescent, and they've now moved on the spectrum of coronary syndromes from a chronic syndrome to an acute syndrome. And overall, coronary angiography has been successful post-TAVR. We look at the right coronary artery and we look at the left coronary artery. These are the numbers that you can see in the different published data. Some of it is observational, the majority of it is observational, and looking at the different TAVR valves that are available to us on the market. But we also have to recognize that unselective coronary engagement is more common, and it is an issue, particularly with large stent frames or longer stent frames. There are predictors of unsuccessful coronary cannulation post-TAVR. And of course, we have to look at the sinus of Valsalva, the size of it. We have to look at the implant depth of the valve that was used. And of course, the type of valve, as I mentioned, that was used. So when we're looking at diagnostic coronary catheters, when you're looking at cannulating the left coronary in patients before TAVR and after TAVR, you see that it was 6.7% using a 3.5, for example, as opposed to 10.7% in those after TAVR. Likewise, when you're looking at your standard coronary catheters for the right coronary engagement compared with post-TAVR, 8.7%. The obstacles are really what I started to tell you: sinotubular junction dimensions, sinus height, leaflet thickness and bulkiness, and so on, the sinus of Valsalva width, the coronary height, and of course the device and procedure itself. So looking at the commissural tab and where it's actually located, and more often now than not, we're talking about commissural alignment and so on. Looking at the sealing skirt height and looking at the valve implant depth, and this was by Udi and his colleagues since 2018. But chronic coronary syndrome aside, we need to focus on acute coronary syndrome. And this is Medicare data from 2012 to 2017. They looked at over 1,400 patients who had TAVR, and then how many of those ended up with an acute coronary syndrome requiring coronary revascularization, about 6,700 patients. But when you look at it, STEMI constituted 9%, non-STEMI 79%, and other, such as unstable angina and so on, was 12%. Alarmingly, that for those who required PCI, 8.6% unsuccessful PCI and coronary cannulation. That is not a small percentage. Now, mind you, this data was inclusive of STEMI and non-STEMI, and perhaps non-STEMI, you have more time on your hands to sit and change your access site. Maybe you're more coaxial if you go femoral than radial, etc. In STEMI, you don't have that luxury, and door-to-balloon time becomes an issue, and we do need to be cognizant that you have peripheral centers that receive STEMI patients as well, who may not be comfortable engaging, the different TAVI valves and so on. So is there anything that we can do? Well, there's a lot of data that right now is being generated to help us predict. So for example, this is a study that was published by Giorgio and colleagues just earlier this year in Neurointervention that looked at the role of cardiac CT in prognosticating or predicting the coronary obstruction and so on with CT. So what they did is they took 200 plus patients and included both the baseline images, and then later on, what they did see is there was good agreement between the baseline, or what they called the virtual CT, and that was obtained 30 days after implantation. So the baseline CT before valve implantation was used to predict virtually what's going to happen to the coronaries and if coronary obstruction is likely to happen. And then there was very good agreement with that captured at 30 days after the valve was in fact implanted. And what you do see is the feasibility. So you see pre-TAVI and then at 30 days, and you see both for balloon expandable on the left-hand side and for self-expanding valves on the right-hand side. And you can see whether you do need, if the risk of coronary obstruction is high, whether you do need some kind of leaflet modification is required. What we do gather from a trial like this is that simulation using CT is feasible, and it did detect obstruction at 25.4% were low risk, 27.7% had high risk irrespective of the valve type, but did necessitate some kind of leaflet modification. The remaining 46.9% could undergo TAVI, a redo TAVI, for example, as long as the first heart valve was a balloon expandable valve that requires that is suitable for leaflet modification, compared with a first self-expanding valve with a larger cage or longer cage. So we need to know these are the three most common platforms that are available of transcatheter heart valves. So you do have the Edwards balloon expandable, a Sapien valve, you do have the self-expanding Evolut from Medtronic, and you do have the Accurate Neo from Boston. I think one thing is to understand, as I mentioned, the sinus dimensions, but to also understand the height of the coronaries, the depth of your implantation, but also a new parameter, which is really looking at the cage, the valve to coronary ratio, and how much of it. Perhaps something like an Evolut is probably less favorable compared to even another self-expanding, the Accurate Neo. But most certainly for redos, the inclination is most likely, at least in our lab, is going to be a balloon expandable. So much to my dismay, I was always thinking that my patients, so I talked to you so far about low risk, intermediate risk, and high risk and inoperable patients, but risk stratification of patients is not the same as age. And much to my dismay, I never thought I would be evaluating patients for TAVI in their early 60s, but it is a reality in the Gulf region. We do see younger patients who are referred to us by our surgeons in the heart team meeting because they have concern about taking this kind of substrate to the cath lab, to the cardiac OR, and putting them on pump or even minimally invasive surgery. So naturally, the next thing you want to do is really look at the coronary ostia height. This particular patient of mine from our hospital had decent height, but they don't always have decent height. And should we be going back to the heart team meeting when you start seeing that, when you start seeing young patients with a height that's not suitable? Should we be going back to the heart team when you see a young patient, but with probable bicuspid valve? Do they behave the same as somebody who has a tri-leaflet valve? Because again, a lot of the data that was shown about coronary obstruction and so on, we're really looking at your typical patients, patients who are suitable for transfemoral and with a tri-leaflet valve. So again, transfemoral takes me to the next point, which is something for consideration. If you start to see more than one parameter pile up for your patients, it's time to take them back to the heart team meeting, especially as they get younger. Why? Because in spite of all our efforts to have commissural alignment and to have a basilica procedure that is being performed and so on, I'm sorry, I have to go back one. So what you do want to see is patients 65 to 80 years old. What you want to do is reconsider your first implantation, because your first implantation really dictates what comes next. So whether it is a surgically implanted valve or it is a transcatheter implanted valve, it will dictate what comes afterwards. And I think we need to consider the center that you're in as well. Is your center capable of doing valve explantation or not? Is your center capable of doing aortic root expansion or not? Because all of these are factors that you need to consider when you're starting to look at not just low-risk patients, but younger patients, in addition, of course, to coronary access. So I'll leave it here to the panel.
Thank you, Dr. Mervat. That was fantastic. So basically the way we're going to do this is we're going to have 10 minutes in between each talk for questions from the audience, if you have, or we'll have some discussion among the panelists. Let me start with Dr. Ahmed. In terms of, so putting this all together, what Dr. Mervat just presented and your practice, how do you factor all this in your decision-making with a relatively young patient, let's say 65, 70, who, when you're trying to decide between a balloon expandable or self-expanding valve?
Yeah, thank you. That was excellent talk, Dr. Mervat. So usually our patient is way younger than the North American and definitely younger than the European standard. What we see in our practice, our average age in Kuwait is longevity is around 75 years, and few people will reach to 80, very few will reach to 90. Referral of 60 to the valve clinic is not abnormal. 55 sometimes if the patient is frail with the comorbidities. Another thing also to add on, our patients unfortunately have a chronic disease at a very early age. So they develop diabetes at a very early age, ischemic heart disease at a very early age, ending up with CKD, ending up with a lot of comorbidities at a very early age, making them kind of a difficult substrate to take to the OR, especially if the surgeon is not very keen to take high-risk patients. So with all of that factored on, yes, we end up with very young patients, and if you only look at the age, you would say what the interventionist is doing, putting a TAVR in a patient who is 59 or 60. But if you really sit in the heart team discussion, you would understand that this patient is actually perfect patient for TAVR.
Excellent. Jeremiah, actually, yesterday we had an interesting debate. You were telling us about your practice, but what's your thoughts on very young patients in terms of like we said, we get a lot of these here, 55, 60-year-old, maybe some comorbidity, but maybe sometimes not, and patient really wants TAVR. What are you guys doing with these very young AS patients?
Yeah, and this has happened, at least to practice in the United States, where, very young, I guess, well under 65, and patients who are even in their early 50s. And I never thought about it until recently when these patients started coming for options about AVR. And specifically people who are working, they're not retired, and people that anatomically are favorable for TAVI do not have any indication for surgery. And in those patients, we have been offering the option of TAVI and thinking in the longevity in the US where everybody thinks they're going to live to 100 and beyond, but beyond that, what we have talked to people about the cadence, often thinking of TAVI as a first implant. We may go all the way through TAVI, TAV and TAV and TAV, or alternatively thinking about surgery as the second procedure. They'll still be in their 60s or early 70s, be low risk, and should be relatively something that could be considered.
Dr. Ruggieri, what's your thoughts on kind of that strategy?
That's in France, we are using to apply the international guidelines. So 75 years old is the age for TAVI, but we have a lot of younger patients with a high risk that is going to TAVI also. The problem today, for example, for a surgeon like me, is that a lot of younger patients want they buy a prosthesis. So I will show you in my presentation later what you do.
Excellent. Medved, let me ask you, in terms of bicuspid valves, when you get, so let's say that patient that you had and that you came, how does that factor into your decision making, your heart team? Are you treating them just like a tricuspid in terms of decision making, or does that push you more towards surgery, or does it change your decision making at all?
So I think over time we've all learned that bicuspid is not one disease, and so there's a spectrum of bicuspid. There are a lot of cases where it's quote unquote functional bicuspid, and you can effectively treat them like a tricuspid valve, and but of course there are some that are not. I think just one point that I want to make sure to mention: in the Gulf region, not only are our patients younger, but they're actually smaller, which makes the issue of coronary access and coronary obstruction slightly more relevant in the discussions, because our patients are smaller, and so we do have to have these discussions with our surgeons if they plan to take the patients to surgery, not even TAVR. They need to consider putting doing a aortic expansion and putting in a bigger valve for future for these patients, because again, many, for whatever reason, don't want mechanical valves.
And has your practice changed, Dr. Ruggieri, in the last 10, 15 years, surgically wise, at least?
For bicuspid, the problem is that it depends from the kind of bicuspid, because for type 1, it's like a tricuspid, so you can use without a lot of complication TAVI. And the problem is the coronary ostia also, because sometimes they are not well positioned. So it's really important to prevent this and the obstruction.
And so we're going to talk a little bit more about durability and valve choice, but Ahmed, how do you factor in coronary disease into your kind of tree when you're treating these patients, lifetime management-wise? So valve choice, what you do, send them to surgery, put in a self-expanding, put in a balloon expandable valve. How does the presence or lack of coronary disease affect you?
So that's a great question. So I think there is a paper just came out for this, but since we are not doing our cases in pump, so we are not obliged to fix anything forehand. If the patient is asymptomatic, if we are sure the symptoms are all coming from the valve itself, we just go forward and do that and do the valve and come back for the coronaries if we need to in the future. We are not complicating the things here. The question is, would you fix the coronaries before the TAVI or after the TAVI? You have to pace the heart at very high limit, and the patient is, if the coronaries are too diseased, you might have a problem. You are putting the patient into great stress, or afterward you are pacing, after putting a fresh stent, you are stopping the flow in the coronaries for some time. The stent's going to get occluded because you are limiting the flow through the coronaries. So I think it's just making it simple. If the patient have coronary disease, get the coronary access preserved, put a very small valve with a good clearance to the coronary ostium, so you can get back if you need to, and just make it simple for the patient in that day.
I see Dr. Mohammed with a question.
I think it's a comment on the coronary. Some of the people or patient where we did PCI, to be honest with you, good percentage of their symptoms improved. And that's why I don't rush and do TAVI like in 1 week or 2 weeks. I give them time, because at the end, I will end by doing TAVI. And the problem we have in the clinic, a lot of people, they know about TAVI, they read about it from their relatives, medical student, they came in with their relatives. Now, the struggle we have in our area, the younger people, and I have a lot of the officers, they are refusing the surgery. And they are 59, 58, and I told them there is another option now, where we can put maybe if the surgeon agree, a bioprosthetic valve. If you are not interested in mechanical valve at this age of 58, 59 to maybe 63, 64, and we did it in few number. And our surgical colleague now, they are, adopting Ozaki procedure on those young people. There is few trends going on in the area. But where is your input from state? I want to hear what they are doing for younger people between 60 and 65.
Well, I think it's going to depend on the center. Every practice, every heart center is different. At our specific center, we don't view age, and we don't have defined cutoffs. For younger patients, we do offer mechanical valves. I would tell you that invariably nobody wants it. We think about routes when we need to do it, and our surgeons are very happy to do that, and I think that's appropriate, especially for people with small annuli. And if the TAVR is anatomically feasible in young patients, we do consider it. We view a bioprosthetic tissue valve surgically and TAVR as the same, at least at our center. But there is controversy and wide practice variation at center to center, and I think it's something we're all going to learn together, but you bring up really valid points.
Excellent. I think we're gonna great discussions. We can have some more after the next session. But next, it's my pleasure to introduce Dr. Jeremiah Depta, who's going to be talking to us about valve durability and what it matters to patients.
Perfect. Thank you very much. You bring the slides up. Oh, do I need to do it? Perfect. This is my first time in the region. I'm really excited to be here and interact with all of you. We're going to talk about durability, and there's a lot of controversy with this and a lot of thought, so we'll dive deep into it. Just go there. Sorry, there are my disclosures. So what is durability, and how do we define it? I think that is a big question mark. What are our current definitions and how relevant are they to our current clinical practice? And can these current assumptions about durability, how informative can they be for our current clinical decision making? Durability has changed over time. We think back to how surgical durability, when we talk about structural valve deterioration, or the guidelines, it was predominantly, did they get re-intervened? And re-intervened at that time was, did they get repeat surgery or not? And then that evolved to getting valve-in-valve. Then the guidelines progressed to being echo-derived gradients, so cutoffs of gradients. And then fast forward to where we are today, where we have the VARC-3 guidelines, which are designed to have more clinically relevant durability definitions. If you look at NOTION trial, 8-year study, and you look at the rate of structural valve deterioration, looking at the various definitions, there is wide variability. And when you go all the way to the left there, which is using the VARC criteria for bioprosthetic valve failure, you see that the rates are significantly lower depending on how you utilize these definitions. And as you start to walk away from purely echo-derived gradients. And so that is the point of VARC-3, is somewhat not stepping completely away from echo-derived gradients, but also making sure that if you see an increase in mean transvalvular gradients and looking at the temporal aspect of it, and you see changes in your Doppler velocity index or your dimensionless index, that could be more informative as opposed to just a single measurement. And does echo really tell the whole story? And does a single measurement of a higher gradient, let's say at post-op day 1 or 30 days, does that portend some adverse clinical outcome? You look at the figure on the left, that's retrospective in all valves out to 2 years. You don't find any difference with gradients that are above 20. And I think, interestingly, this is not a valve-in-valve talk, but you look at the VIVID registry looking out to 8 years, comparing the gradients above 20 versus below 20, do not have any effect on long-term outcomes. And a more recent published study looked at the 2-year mortality outcomes based on what the mean gradient was and looking at the risk for death. And what you found is that there is a nonlinear relationship between mortality and gradient. Somewhat counterintuitive, and people may say. What you found is actually using the discharge echo or using invasive measurements that people who have a lower stroke volume and lower gradients actually have a higher mortality. So again, it's somewhat counterintuitive, and we may not have the full story. So what is the why does post-TAVI echo not necessarily reflect a true gradient? And this we all know, and the case that was presented earlier today showed an example of that echo-derived gradients versus cath-derived gradients. Cath will directly measure the pressure. Pressure in an echo is measuring velocity. It is a simplified form of the Bernoulli equation, and Dr. Abbas at Beaumont Hospital has done wonderful work to help us through this. But it is assumed, and it doesn't take into account pressure recovery and all sorts of things that are in the Bernoulli. So it is echo-derived. It measures flow. It doesn't measure pressure per se. We know that there is wonderful concordance in native valve severe AS when you talk about echo and cath gradients. But there is the opposite when you talk about a bioprosthetic valve. There is discordance with it. And we have found that there is discordance between echo and cath. And we find that discordance is greater with balloon expandable valves compared to self-expanding, and that is partly due to the difference between laminar flow with balloon expandable valves versus the turbulent flow that is with self-expanding valves. And so it's important that we just don't rely on these echo hemodynamic measurements, which could falsely lead to reintervention. Even going forward, if you look at the smallest balloon expandable valves, that discordance is found even more. So again, I would say that invasive, directly measuring the cath gradients would be informative prior to moving forward with intervening. We shift forward to what BARC 3 did with bioprosthetic valve failure, which is more clinically relevant, patient-focused, meaning am I getting reintervened? Am I have a valve-related death? And then it comes up to something that is a complex amalgam of both, where it has both looking at echo, invasive measurements as well as bioprosthetic valve failure, and that is really the current definition of clinically relevant durability. And I think we have to ask ourselves, what is important to patients? Obviously, every patient wants the best short and long-term outcomes. We want to have something as durability. We can ask ourselves, what is the definition of durability to a patient? And I think beautifully in the first session about future treatment options and repeatability. And this is, I think, even though I'm here to talk about durability, what is more important to patients? Durability, repeatability. And I think both are equally important, and it should be driven by patients' life expectancy, their anatomy. We're going to have a talk about leaflet durability in a bit here. We talked about coronary access after the initial plan, doing repeat TAVI, commissural alignment. Coronary disease is a problem, beautifully talked about in the first session. A lot of patients will have it, especially younger people. And we do find issues of being able to do coronary access. And this is a study where it was directly done. And you can find there are differences, significant differences between balloon expandable valve versus self-expanding. And then also the repeat TAV and TAV being feasible. And this is 345 patients who underwent post-TAVR CT, and the idea of sequestering the sinuses in a repeat TAV and TAV. You found 45% would not be feasible to be able to get TAV and TAV without obstruction and self-expanding versus 2% for balloon expanding. And that's really important as we think about lifetime management. We can't dive in this completely, but patient prosthetic mismatch is a hotly debated topic. And I bring up this slide alone just to show you an example. The idea of measured PPM versus predicted PPM. So what is measured? Measured is what you get your EOA indexed off of the echo. Predicted PPM is using the EOA off of whatever valve choice you have and indexing it. You can see that there are significant differences in the rate of how you define PPM. And if you look at outcomes, so this is in the Partner 2 and S3I registry, outcome up to 5 years, SAVR, if you have severe PPM, and that's predicted, it is associated with a higher risk of mortality and rehospitalization. TAVI is not. So PPM, something that we discuss all the time, before I think we start making judgments about how we're going to treat, we need to define it. So kind of my takeaways is that the definitions of durability are evolving. It is just not on echo alone. There is significant discordance between echo and cath. and that concern about echo-derived gradients and ppm really should not be the primary factor in valve selection, and then we should not discount repeatability, and that was discussed in the first session.
Fantastic. Thank you, and you held the time. That was great. Okay, so we'll open up to discussion again if there's any questions from the audience. But I'll bring up a point. I'd like to get different perspectives from different panelists. So let's say we have a 62, 64-year-old, relatively low-risk patient, really wants TAVR with a small annulus. So choices are surgery with expanding the LVOT. There's two different valve choices. Dr. Mirovic, give me, what are you doing? How are you approaching this in your practice or in your group practice?
So I think what we do is we do go back to the heart team for these patients, and we do consider whether TAVR needs to be taken off the table or not. Patient preference is center and core to what we do, but we weigh risk and benefit. So fortunately, our surgeons are capable of doing root expansion. So if this patient was a surgical candidate, we'd have an honest discussion with them about all these things, durability included, that perhaps root expansion is an option. But had we not had somebody that can do root expansion, I think TAVR is reasonable in these kind of patients. And although initially your initial hemodynamics may be better with self-expanding valves, we just saw some evidence about the sequestration in the sinuses and so on. Personally, I have issue with how we're defining durability. I think a lot of the time we are using evidence and referencing very old surgical data that was not standardized, prompted primarily by presentation and symptoms and so on, whereas many went undiagnosed in this old surgical data. So if there was no routine follow-up for these kind of patients to get echoes and hemodynamics and so on, if they remained asymptomatic. And I think we've certainly lowered the bar when we introduced TAVR. A lot of these even get CT scans to start looking at valve durability and halt and all of these issues. So,
okay. Dr. Gier, what's your thoughts?
Well, in our practice, this patient is a surgical patient, and we applied the international guidelines. So if it's a low risk young patient, it's a surgical patient for us. And if his annulus is small, we perform an aortic root enlargement.
Let's say the patient's 75 with a small annulus, and you're deciding between TAVR choices. Now, what are you doing?
If he's 75,
in terms of choice of valve, and how do you weigh the annulus size, the coronary? How do you factor all those things in your decision on which valve to put in?
I will prefer TAVI, and I will prefer a balloon expandable TAVI because it's a potential patient with coronary problems in the future. So the access to the coronary it will be better. For sure.
Dr. Ahmed, how about your thoughts?
So we have a few of those 65s and 60s, as Dr. Mirvat was saying. And we factored many things, to be honest. Longevity for this patient, particularly if he's going to live longer, expected to live longer, or he's 65, hopefully that's going to make it to 75. That's one thing. Second thing, we sit head-to-head with the surgeon in the same table, and he sees his predicted surgical morbidities for this case, and we say our predicted surgical TAVI, and we present them both to the patient. Like a joke aside, is in Twitter every interventionist uses OCT, and every surgeon do annual enlargement, but in reality it's not. So we have to bring this to the table and discuss with in that particular patient, would he really go for annual enlargement? Because then the biggest nightmare is putting a 19 valve in a patient who is 150 kilogram, and you end up with a surgery which is worse for the patient than his valve initially. So discussion with the surgeon, what he's happy to do and what he can deliver and what you can deliver to the patient, and patient agreement at the same time.
Dr. Mohammed?
And I think I will echo all what you said, and I agree with Mirfat. Especially in our society, the problem we have with bioprosthetic valve, which was deployed or done by the surgeon a few years ago, it was a typical mismatch. typical mismatch. Since we started the TAVI program the last 12 years in Saudi Arabia, the surgeon, they were involved in some of the center, heavily involved, and they learned, same like us, from the imaging, and they changed their practice. And I can assure you, some of them, at least in our institution, and the patient we refuse to do TAVI, they take them and they put sutureless valve. And they depend on our measurement, imaging stuff. But when we come to the talk by Jeremy today, it's the durability. We are suffering from this. We see more structural deterioration of the sutureless faster than TAVI. And to be honest with you, the TAVI problem so far, it's very decimal. Like very little number of our patients who had TAVI or TAVR and TAVR yet. I'm sure in the future we will see more of those, but again, if the patient is old enough, above 75, I think I will not argue with the surgeon too much, and we will do TAVI above 75. One of the things we saw, even in the elderly patient, where we did left main stenting prior to the TAVI, we had at least 2 patients. They develop instant restenosis at the end of the first year of the TAVI. You're going to see such problem progression even in the elderly patient.
Excellent, thank you. Yes.
Okay, we are aware of the comparison between the Sapien and the Evolut in the small annulus. Do you have any idea comparing the accurate neo in these cases? Because it's a self-expandable and it still preserves the coronary axis. So is there any comparison?
Not from a hemodynamic, I mean, hemodynamic, yes. I think that data is going to become forthcoming, but I think your point about the coronary access and repeatability with accurate neo, I think it is going to alleviate some of the problems compared to the current Evolut platform. I know that there's going future iterations of what they're going to do within Medtronic, but some of the issues with repeatability, accurate neo too will step around that. So.
Jeremiah, I had a question for you about durability and implant depth. We know a lot about implant depth, especially in valve-in-valve, affects durability and hemodynamics. Is there a role for implant depth in terms of hemodynamics up front on the initial, and also, you know, how it relates to pacemaker need and...
Yeah, I think you bring up a really, especially in a younger patient, and we were discussing what would we do with that young patient. For me, it's repeatability. And making sure that even if we don't do TAVI and TAV in the future, that we have the option. And so when you talk about implant depth in somebody that you're expecting to repeat, and I think we should always kind of say, okay, expecting, but it's significantly a young patient where we may have to repeat it. We all talk about high implant, you know, reduce the risk of pacemaker. But in somebody who has a narrowed STJ or a smaller root, and we do a high implant, we can put that balloon expandable above that STJ, and we'll have an issue with sequestration. And so for us, we'll put a virtual valve in, and we'll see how deep do we need to be so that it's below that STJ, so we're not going to sequester it. And we may say, well, I'd rather have a potentially higher risk of pacemaker implantation to know that I can potentially repeat it. And so that's what we've been doing routinely in our practice.
Great. One last question in terms of pacemaker. So we haven't talked a lot about pacemaker in terms of your decision making. I think the risks have gone down tremendously as people have been using more high implant techniques, and you know, people are getting into the low single digits, especially with the balloon expandable. Does that still play a role in your decision making, Mirovet, like the risk of pacemaker when you're deciding on a patient which valve?
So I factor it in because I'm a cath lab director and I have to consider budget. And in the Middle East and the Gulf, it isn't a package, right? So every valve you use, every balloon you use, is billable. So for leaving cost aside, I think we've all seen with better iterations of the valves, more experience of implantation, the numbers of pacemaker rates and PVLs are actually much lower than the initial trials. And so now we're still quoting the initial trials when we're consenting patients, but I'm wondering if we should be changing that and really just quoting our own center numbers for our patients. In our center and in the Gulf TAVR registry, what we do see is the pacemaker rate is in fact low, and it is lower with balloon expandable valves, that's for sure.
Okay, I think we're on schedule, so we'll go with our next session. Dr. Ruggieri, please. Dr. Ruggieri will be talking to us about valve interventions and also new technologies and directions with valve leaflets.
So thank you very much. Good morning, everybody, and thanks to Edwards Society to invite me. To give you my surgical point of view, I'm a hybrid surgeon, you know, I perform TAVI and surgical AVR, so maybe I can give some key consideration different from interventional cardiologists. I will talk to you about valve-in-valve intervention today and this new RESILIA technology. These are my disclosure. As you know, bioprosthetic valve implantation increased dramatically since 20th century in US and Europe, and the results, the good results of TAVI, the impact in this expansion of the tissue valve segment to more younger patients. And this is the situation today in France. As you know, more than 90–95% of valves are biological implanted. And there are multiple factors responsible for this increasing, because this is a good choice for all patients that are the big portion of treated population, because the better quality of life of bioprosthesis without anticoagulant, the improved durability of the third generation prosthesis, the mechanical better durability, but not better long-term complication and survival, the acceptable risks of redo aortic valve replacement, and the option of valve-in-valve that is a safe option for structural valve deterioration. It is the only one that can be treated by valve-in-valve, like with tear and calcification, and different from the non-structural valve dysfunction that we can treat only by surgery. So there is a really important role of a continuous lifetime management that we have to do, especially for younger patients. And we have some implant that will be performed during the life of the patient, and it depends from the age at the first AVR. We have to say also that at the moment, in some cases, especially for younger and low-risk patients, reoperative surgical aortic valve replacement remain the patient's safest and most effective option. But valve-in-valve TAVI is an important component of this lifetime planning, thanks to the very good results of this procedure in immediate post-implantation. But we need long-term follow-up that is still poor in literature. So my problem today as a surgeon is that I have the patients that are very young, and I take an example of a 50-year-old patient that wants today a bioprosthesis. So as I have something to do at this moment, at surgical moment, to improve and to optimize the future of this patient. And I need a thoughtful planning regarding prosthesis choice, root anatomy, valve size, anatomic orientation, the radiographic signature of the annulus, valve annulus, and the coronary artery preservation. And this planning can greatly improve the chances of the successful intervention as a redo or valve-in-valve for severe structural valve deterioration. So I have some ideal anatomical features that I looked in the patient. The easy thoracic anatomy, the large aortic annulus, the high and well-developed coronary arteries, the tall aortic sinuses are all features that give me a good patient for the future reintervention or reoperation. And the ideal prosthesis that I would like to implant for this patient is easy to implant with long-term durability, a large effective orifice area, an expandable sewer ring and stent frame at low pressure, a unique, easily seen radiographic profile, and a low profile with leaflet implanted on short stent that won't obstruct native coronary arteries. Understanding this factor and careful surgical planning can optimize the chance of future access. As we said, the PPM must be avoided. So we have to avoid in younger patients 19 and 21 millimeters valve, because this mismatch can never be overcome with the subsequent transcatheter procedure with poor survival at long term. And the effective orifice area for each patient, for each size patient prosthesis being implanted can be identified. So we can predict the mismatch before the intervention, thanks to the measure of CT scan of the annulus of the patient. So if the dimension suggests that the minimum size valve need to avoid PPM will not feed, we have to prepare to do a root enlargement in this patient. This is an option that we can use when we have a patient with a small bioprosthesis and we want to realize a valvular valve. So we can crack or fracture the sewer ring to allow for additional expansion and to optimize the hemodynamics. Some, but not all, surgical valves can be cracked. And some require a high pressure balloon, placing additional risk for the patient. So we have to implant in young patient a easily expandable sewer ring, prosthesis with the easily expandable sewer ring, a stent frame, or in addition, stentless valve frame are made of a material that allows for easy expansion. Another important point is the radiographic signature. It is crucial that the sewer ring is well visualized. So the ideal deployment position can be reached with this visualization of the ring. But not all valve or valve conduit are have radiopaque signature. So in these cases, marking the annular plane with the clips or radiopaque markers will make a future valving valve much safer. We have to prevent coronary artery obstruction. So we have to pay attention to post-orientation of the bioprosthesis in relation to the coronary ostia that can be distorted, especially in the young patients that are often bicuspid patients. If we have low coronary ostia, we have to choose a low-profile prosthesis with the leaflet inside the sewer ring. And if we have deficient sinus segment or high risk for sinus sequestration, we have to consider the root enlargement, a sinotubular junction widening, or aortic root replacement with a Valsalva graft. The subsequent access to coronary artery is important also after valve-in-valve implantation. So it's important to use a valve that facilitates future coronary access with low frame height and open cell geometry. And the coronary access can become challenging after valve-in-valve procedure, always for the frame height, the leaflet position relative to the annulus, so in supraannular prosthesis is more difficult, and depending from the alignment between the native and the prosthetic commissure. This is the new prosthesis Inspiris Resilia aortic valve from Edwards Society. It is a prosthesis that was designed for younger patients in order to minimize calcification for long-term durability and optimize valve-in-valve intervention. Thanks to the stable capping, that is an anti-calcification process to block free aldehydes and reduce calcium binding, and thanks to the glycerolization that eradicates exposure to unbound aldehyde groups, the Resilia tissue mitigates residual aldehyde and is a key factor for calcification. And this enables the valve to be resilient and easy to use because it's stocked in stable dry storage. Another important technology of this prosthesis is the V-Fit technology that allow to put inside this prosthesis a larger size of TAVI because the stent is expandable. These features are not yet been observed in clinical studies, just in some reported cases to establish the safety and the effectiveness of this prosthesis, but is a really important technology when we think to the future of a patient, of a young patient implanted. The Resilia tissue prosthesis is shown in literature and in multiple studies. It's improved anti-calcification and hemodynamic properties, and has an encouraging safety profile and stable hemodynamic performance with no SVD at 5 years. So I want to conclude with some messages. When we think to have to implant a biological prosthesis in younger patients, we need a thoughtful planning, a lifetime management in order to think to the future of the patient that will be implanted more times. The reduced surgery remain a good option today for younger patients at low risk, but the valve-in-valve is a very good alternative, especially for elderly and high-risk patients. We have some data, but not very good long-term data for this valve-in-valve procedure, so we have to wait for in the future. And if the Anspiris Resilia is the ideal prosthesis, we don't know now, but the initial results are really good. So anyway, the decision made at the time of surgical AVR are crucial and have to be planned. Thank you very much for your attention.
Thank you very much, Dr. Ruggiero. That was fantastic. You know, I think of this as a lot like a monopoly. Surgery used to have a monopoly, and so their progress was slow. But the fact TAVR, and now you have multiple TAVR valves, the progression and the improvement in technique and what's being done has dramatically increased, I think, in the last 10 years. I really like the point you mentioned about the aortic root replacement. Our surgeons, for instance, have a very low threshold in these small annuli or small roots to kind of do a root replacement and in preparation of what they're going to need in future. Is that become much more of your practice, or do you see it as much more thought of kind of future ramifications?
Yeah, I thought that we have to think about it. So it depends from the patient, and we have to perform the good operation for the good patient in that moment. So it is an option. We can use it. We have to know that it's an important factor for the future of the patient. Because if it's only for implant just a bioprosthesis in a patient in one moment and don't think to his future, is not good today, I think.
And I think, you know, one of the other things to me, this decision-making is all complex. You know, we have the durability, the lifetime management, the surgical choices. It's become not so simple as just TAVR versus SAVR, but there's a lot of other factors. And there's local factors as well, what you're doing, what's happening in your own country, in your own region. And all of this boils down to none of this can be done without a proper functioning heart team. I mean, if you don't have a good collaboration between the surgeons, the interventionalists, and the general cardiologists, kind of you can't reach the proper decision making. What's best, because the patient will suffer. How are things going along in your practice, Ahmed? And what are things that is it much improved than how it used to be in terms of our team discussions?
I think what he presented is the dream. That because if you go with a TAVI valve in the beginning, then you are making the surgeon life hell, because he had to dissect through TAVI, which is quite difficult since there is a lot of adhesions. So if you started with a periprosthetic valve that's going to last so long, to the limit that the patient can get old and he have or she have a valve-in-valve later on during life, that's the perfect scenario for a patient. That's you start with a surgical valve, enlarge the roots, then go with the largest surgical valve, then he have a valve or she have a valve-in-valve later on during life. That would be the best scenario for any patient of mine. I think, to be honest, though sizes, as the sizes get smaller, more talk for TAVI in our region is going on. And as the patient lower surgical risk is going more toward surgery, and as the surgical risk goes higher, we go more forward with TAVI in our place.
We have also to say that bicuspid population is the young population, so is the most important part of this patient. And so today for TAVI is not a very good recommendation, and the problem is also for the future of the patient is really important to do planning.
And I think everyone has to be, we all have to learn CTs. We all have to learn anatomy evaluations. We all kind of have to be able to evaluate. I think surgeons are learning much more about CTs and looking at these. So proper discussions of all these details, anatomic factors, clinical factors, putting it all together and kind of to serve what's best for that patient. Jeremiah, how are you guys? You told me about your valve clinic a little bit, but how are you collaborating with your surgeons kind of to reach that optimal choice for the patient?
We work really well with our surgeons. It's a very collaborative approach. We review the CTs together, and I think we have both learned an incredible amount. And also thinking outside the box on these patients. We do still take the patient's concerns and preferences and their values, as we all should. The bicuspid group is a very unique group to deal with. And there are straightforward bicuspid cases where, all right, this is a high-risk TAVR anatomy, or TAVI anatomy. We're not going to do that. We don't offer that. They have aortopathy that needs intervention. We're not going to do that. They have surgical CAD. We're not going to do that. But then you find there's a fair number of patients who you can do TAVI on. And then finding solutions and having those discussions with younger patients and the surgeon and the interventional cardiologist working together to help that patient navigate their decisions. Because, and that's the problem, I think, as humans, kind of the saying of kicking the can down the road. Patients are very happy to do that at times, but we also have to guard against that if it's not right.
Yeah, and how is it working in France in terms of your collaboration with your colleagues?
The collaboration is very good, but we have always a lot of discussion about patients. It's not always easy because each of us has his point of view, but we try to choose the best for each patient. So I think that the collaboration is good in this moment, and it's preparing the collaboration of the future, because it's hard today, but maybe in 10 years it will be much better.
So let me ask just we have a question.
Yeah, so great talk, the last talk. So regarding the valve, cracking the valve, I don't know if you have any experience with that. I mean, you can elaborate on the experience that you have, and also how easy to do it, and if risks have, and what are the risks have associated with it, and how you can tackle them.
So I can speak to that. I was on the paper that came out in TCT about the TBT registry data, but prior to that, we fracture routinely. We're a referral center for fracturing and basilica and things related to that. It has to be done correctly. And Mid-America in Kansas City, Keith Allen's group has done a large amount of research and just the technique of how to do it. We fracture, again, routinely. And when you do fracture, it has to be pre-specified. I don't feel that you should implant the valve and then measure the hemodynamics and then decide I'm going to fracture after, because oftentimes your valve choice will be dictated based on if you're fracturing. For example, you might have a smaller valve if you're not going to fracture. You'll have a larger valve if you are. So that has to be pre-specified. In that TBT registry, again, the first look, this is only done in balloon expandable. It did show that there was a significant effect on hemodynamics, meaning the hemodynamics were better, which is good. There was a risk for higher risk of mortality and a higher risk of bleeding. The bleeding, a little bit of a head scratcher, but what we think it is related to is that when that true balloon bursts, if it gets caught, and you can't get it out of the E-sheath or out of your sheath, that then you're going to have a vascular complication, which then increases the bleeding risk, and that's what we felt as the group. The idea of that paper was not to say fracturing is bad. I think what it speaks to is that fracturing is not universally applied. There's very high volume centers in the US, and there's places that are rarely doing it. But I do think we need to have best practices. So if you are considering it, I think reaching out to the places of best practices to be able to figure out the best techniques.
Thank you. I'll ask one final question. So we've talked about the valve technology, Mirvet, a lot of progress. If you had to design the future of valve, what's missing from the current generation products? Like what would you like to see in the next generations?
I don't think we have truly retrievable valves at this point in time, and I think this is what's really missing. That's in terms of the valve technology. What is missing is a solid heart team meeting that is not center-specific, but rather region-specific. And actually, the Ministry of Health in Saudi Arabia has started a virtual heart team in a virtual hospital, and we actually started with TAVR. So we actually have weekly heart team meetings, and and the purpose of it is when you have the run-of-the-mill TAVR, it's run-of-the-mill TAVR. But once you start talking about coronary access and narrow annulus and so on, these need to be referred to center with the right expertise, where they can get the root expansion, where they can get the basilica, or they can do the valve and valve, so on. So that's what this virtual MDT serves, is that now you don't have to do the TAVR in a center with less experience. You can now shift them to elsewhere, or at least be guided by a heart team discussion that is wider and involves more expertise across the region.
All right, thank you. I think our time is up. So thank you all for attending the session. Hope you enjoyed it, and see you next session. Thanks.